Welcome to AETCM, the emergency medicine channel. Today, I'll be discussing about the topic thromboelastography and rotational thromboelastometry. So, as introduction, thromboelastography was first described by Hartert in 1948. It was in the USA. And thromboelastography and rotational thromboelastometry, ROTEM, they usually provide a global information on the dynamics of clot development, stabilization and dissolution that usually reflect in the in vivo hemostasis. So, usually what occurs is that when a vessel injury occurs, initially there will be clumping of platelets. So, that is what initially occurs.
Vasoconstriction.
Yeah, sorry. There will
First
be
of all, vasoconstriction.
Initially, there will be a vasoconstriction, following which there will be clumping of platelets and RBCs. Following which there will be the arrival of fibrin, and they will be forming the process of a clot.
The fibrinogen will be converted to fibrin.
And
so whenever there is a vessel injury, when blood oozes out through the vessel, what happens is there will be a vasoconstriction that area to prevent further blood loss. And then all the platelets and the RBCs and all these small RBCs will come to that area and that tries to control the bleeding. So a clot will be formed. And on top of that, the fibrinogen will be, which is in the circulating the blood, will be converted to fibrin, which forms a...
it's like a net.
Yeah, it forms a net over that. It helps in further stabilization of the clot. And ultimately what happens is that vessel gets healed. And finally this clot gets lysed. And that is cleared of the circulation. That is a normal coagulation process. So this thromboelastogram TEG is an indirect way. So it's an indirect way to see what exactly is the problem in clot formation and lysis. Okay, so it is a graphical representation of the clot formation process and the lysis part. So depending on the variation in the graph, you can understand where exactly is the problem and what product to be transfused. Whether you have to transfuse FFP, whether you have to transfuse cryoprecipitate or tranexamic acid, whatever it is, platelet. Depending on the graph, you will get an idea. Okay.
So basically, what is the uses of thromboelastography, and also in ROTEM is also can be used. It is mainly used as a point of care test. It usually takes a time of around 30 minutes, and it's used in a number of situations, and these include trauma, major surgeries, including the hepatic surgeries and transplantation, major blood loss, and also in the cases of transfusion. And also in case of pregnancy. Pregnancy is usually a hypercoagulable state. So, a hypercoagulable state. So, that can also be graphically determined by the thromboelastography, and the assessment of the platelet function disorders, and also hypercoagulable disorders can also be assessed by this method. And DIC. DIC can be by the graphical representation, we can be able to identify the DIC, and also it is used in the investigation of individuals with an unclassified bleeding disorder to find out which factor is contributing to its bleeding manifestations. So, the principle and methodology, usually this is the diagram of a TEG. So, this is a thromboelastogram. So, this device is mainly contains a torsion wire. It contains a torsion wire, it contains a cup, it contains a pin, and so these are the main three components involved. So, initially in thromboelastogram, it is the cup that rotates. So, that is the main point in thromboelastogram. And in ROTEM, in rotational thromboelastometry, the pin is what is rotating. So, in ROTEM, the pin rotates, and in TEG, the cup rotates. So, that is one of the major differences between TEG and ROTEM. So initially what we use is, we can use the complete whole blood can be used, and but it is not usually seen in common practice. So we use a citrated whole blood, and it must be recalcified because calcium is an important integrating factor in the clotting pathway. So that's why we must add additional calcium to initiate the coagulation, and must be incubated at a body temperature of 37 degrees Celsius. And so this is mainly regarding how the blood must be introduced. And within the cup, the pin is suspended and it is connected to a detector system. So the detector system differs between TEG and ROTEM. So the detector system in the case of TEG is the torsion wire. So this is the torsion wire, and this is the main detector system of the viscoelastic motion in the case of TEG, and there is the presence of an optical detector in the case of a ROTEM device. So in the next slide I will be mentioning about the optical detector. So this is the diagram of a ROTEM. So ROTEM is also based on a, we initially provided initial LED light source, and there will be a reflection through the mirror, and then there is a presence of a detector which is a optical detector. So this optical detector is what determines the viscoelastic motion in the case of a ROTEM device, and the torsion wire is what determines the viscoelastic motion in the case of a TEG device. So yeah, so in the TEG machine, the cup oscillates in a arc of 4 degree 45 seconds every 5 seconds. So that is the cup is what is oscillating in the case of a TEG machine. So that is the important thing. And in the ROTEM machine, it is the pin which oscillates in a 4 degree 75 seconds every 6 seconds. So what usually happens is that when the blood clots, there will be the presence of a fibrin platelet strand formation. So when it occurs between the cup and the pin, the viscoelastic strength of the clot increases. So that's how the amplitude of the clot and the stabilization of the clot occurs. So that's how it is determined in the graph. And the rotation of the cup is transmitted to the pin in case of a TEG device, and in the ROTEM device, the motion of the pin is impeded by the viscoelastic substance. Okay, so this is detected and the trace is generated, and when the fibrinolysis occurs, the whole clot platelet factor gets dissoluted. So following which the movement of the pin increases. So the amplitude also overall decreases.
So this is basically the physics of ROTEM and TEG. It is not for us.
So this is actually the thromboelastogram.
But this diagram is important.
So thromboelastogram, it has the following components. So mainly we can differentiate, we can separate between the maximum amplitude. So this is the MA, maximum amplitude. So till here is the region of the clot formation, and here is the area of the fibrinolysis. So where the clot gets dissolved. Okay. So initially we have an R. R is called as the reaction time. Reaction time is usually what is it is the time from the beginning of the clot formation to the
Beginning of the test.
Beginning of the test.
Beginning of the test to the initial fibrin formation.
Initial fibrin formation.
R. So here it will be. Here it will be the beginning of the test. Yes. This point. And till here This is called the R, right?
Yes.
So here is the place where the initial fibrin formation
Occurs.
happens. Okay.
And so the R interval is where from the initial starting of the test till 2 mm of the clot at the amplitude.
I'll just give you a revision of what I've already mentioned. In case of a bleeding, in case there is a bleeding from the blood vessel, naturally your body has got a tendency to clot. So initially the first thing is what? Vasoconstriction to prevent blood loss. Then all the platelets and other RBCs, small RBCs will come to the area and then form a clot. And then the fibrinogen which is already present in the blood will be converted to fibrin, and that forms a net inside the clot, and that stabilizes the clot. And over a period of time that wound gets healed, and after some time this clot gets lysed away. So that is what is represented here. So from here till here is the clot formation, and from here onwards goes down like that. That forms, this is the lysis. Okay. So this much is the coagulation part, and here is the fibrinolysis.
So, so initially we have the reaction time, the R time. So this interval is between the starting of the test and the amplitude of 2 mm, and between 2 mm and 20 mm. So that is the minimum amplitude which is required for a clot stabilization. So that is determined by the K time.
So K is basically already it's kinetic. That is the time taken to achieve a certain level of clot strength.
Yes.
That is K time.
K time.
Got it, no? So R is basically time of latency from the start of the test to the initial fibrin formation. So K is time taken to achieve a certain level of clot strength. Okay.
So then this what is determined as the alpha angle. So it is alpha angle is a determinant of how fast
so
the
but
clot
this
formation
K is
occurs.
dependent on fibrinogen. K. Fibrinogen to fibrin conversion, right? So that the minimum amount of clot strength is based on how much of fibrin is formed.
So in case of R, it is mainly determined by the clotting factors. So the clotting factors is what determines R, and in case of K time and the angle. So the how much fast the clot formation occurs. These K time and the alpha angle is mainly by the fibrinogen. So it determines fibrinogen. And the maximum amplitude.
Can you just clear away that those things?
Yeah.
The diagram. Yeah. It becomes much more clearer.
So the alpha angle and the K time, these both are dependent on fibrinogen.
So basically in this diagram, we should know about few things. One is the R time, then the K time, this one, the K time, then the alpha angle. This angle is called the alpha angle. Then this one is the
maximum
amplitude. Look at it. This is the maximum amplitude, right?
Yes.
So the time to achieve the maximum amplitude, this one, that is TMA. Okay. Then comes lysis from here onwards.
So these are the determinants in the case of a thromboelastogram. So again, TEG versus ROTEM. So initially, as I mentioned
It's
before,
not complete. LY30 you have to mention. Time to maximum amplitude. Maximum amplitude means the represents the ultimate strength of the fibrin clot.
So this is MA is what determines the ultimate strength, and MA depends on the platelet. So that is what is determining the ultimate strength of the fibrin clot.
And then LY30,
So LY30 is
the amplitude at 30 minutes after the formation of, after maximum amplitude.
So from MA to the after 30 minutes, the
That is
amplitude
LY30.
is determined as LY30.
So the normal LY30 should be 0 to 8 percentage. Got it, no? Compared to the maximum amplitude, only like 0 to 30 percentage should be, LY30 should be only 0 to 30 percentage, that 8 percentage less than the maximum amplitude. If it is more than that, it means lysis is happening. Got it, no?
So
That the lysis is going at a rapid pace. It shouldn't be like that. Normally, if in a TEG should be like this only. The R should be between 4 to 8 minutes, K should be 1 to 4 minutes, alpha angle between 47 to 74 degrees, maximum amplitude between 55 to 73 mm, and LY30 should be 0 to 8 percentage. But if there is some problem in these things, if suppose there is a increase in R, that means clotting factor deficiency is there, or the patient is having hemophilia. In that case, you will have to transfuse clotting factors. So FFP you transfuse. Got it, no? Whereas if there is a decrease in the alpha angle, or if there is a
K prolonged, increase in K.
Yeah, not increase, if it becomes increase in K or a decrease in the alpha angle, that means
we will give cryoprecipitate.
Cryoprecipitate has to be given. Okay, if the maximum amplitude is less, normally the maximum amplitude is this much. If the width of the maximum amplitude that is less, then we'll have to transfuse platelet.
And if LY30 is increased, then we must what we must transfuse is the we must give an antifibrinolytic. Example, tranexamic acid.
So only you have got options. You need, after getting a TEG, we want to know whether you will have to give FFP, cryoprecipitate, platelet, or tranexamic acid. Got it, no? If the R time is prolonged, give FFP. If the
K time is prolonged,
K time is prolonged, if the alpha angle is acute, reduced, you give cryoprecipitate. If the maximum amplitude is decreased, you give platelet. And if the lysis time is prolonged, you give tranexamic acid. Okay.
So this again the TEG versus ROTEM. Mainly there is a difference in the terminology, but both of these explanation remains the same. So in case of the clot initiation, the R time, in TEG we tell it as the R time, but in ROTEM it is mentioned as clotting time. And we have told about the kinetics time, the K time. That is the time in minutes for the clot amplitude to increase from 2 to 20 mm. And in case of TEG, it is kinetics time. In ROTEM, it is clot formation time. So CFT. So that is the one another difference in the terminology. And the alpha angle remains the same in both TEG and ROTEM. And the peak amplitude or the maximum strength of the clot is mentioned as maximum amplitude in case of TEG and maximum clot firmness MCF in the case of ROTEM. And fibrinolysis, as I mentioned before, the lysis at 30 minutes and lysis at 60 minutes, the percentage reduction. We can tell it as LY30, LY60. So that is mainly mentioned in TEG, but there is another entity called as a lysis index. Lysis index is the percentage reduction in the maximum clot firmness that exists 30 minutes after the clotting time. So it is starting from the initial aspect. I will just explain in the next diagram what is the difference between a LY30 and LI30. So here they have, here we can see that the LY30 is the gap between the time is that amplitude decrease, percentage of amplitude decrease from the starting of the maximum amplitude and post 30 minutes. So that is the LY30 in case of TEG. But
so you look at the amplitude at mark the maximum amplitude. After 30 minutes, you see what is the amplitude.
Maximum amplitude.
So that is L by 30 amplitude.
But
If
in
it is-
case of ROTEM, we can see that it is starting from the initial plotting time itself. That's from the R time. From the R time, post 30 minutes, we mention the amplitude. So that is what is called as LI 30. So that is the difference between LI 30 and LY 30.
So in TEG, it is from the maximum amplitude. It's calculated from the maximum
So amplitude.
Whereas in the ROTEM, it is starting from the
Post clotting time.
after the R. Okay.
So that's the difference. So this is mainly the previous slide itself, like I just mentioned about. Now I'm again mentioning about rotational thromboelastography. So in rotational thromboelastometry, we can see that the initial coagulation time. So the clotting time or the coagulation time is determined by the coagulation factors, anticoagulants, tissue factor expression. So that is what determines the coagulation time, and the clot formation time is also determined on the coagulation factor, anticoagulants, fibrin degranation products, and also tissue factor expression. And we can see that the maximum clot firmness or the maximum amplitude as in TEG is determined by the platelets, fibrinogen, factor 13 and colloids. So that's what is the determining factor in that. And we can see that the lysis. So in there is another entity called as the maximum lysis in the case of ROTEM, and the clot lysis index. So the lysis index at 30 minutes and 60 minutes post the end of clotting time. That is determined by the fibrinolytic enzymes, fibrinolysis inhibitors, and factor 30. So this is again the diagram. Repeat it. So there are certain TEG modifications. So initially we can use the complete whole blood without usage of any additional clotting additional components. But in case of TEG modification, we have the following components called as the kaolin. So the TEG test, there are certain modifications for TEG test modifications. So the first one is a kaolin. It's a activating agent which activates the clotting pathway. So it is similar to the APTT in the value determination. This is mainly for theory purposes. And the next one is the rapid TEG. So rapid TEG is mainly used in the case of trauma. In trauma settings, to get the initial values for determining the transfusion of the selected blood components, we start with the rapid TEG. So that is mainly analogous to the APTT. And the reagent uses tissue factor and kaolin. And there's HTEG. HTEG is it's mainly based on a heparin. Is added as the heparinase. The heparinase is the reagent which is involved. And we have a functional fibrinogen TEG. So that is basically the reagent which we add for the clotting factor activation. So all these are clotting activators which we add initially to assess the complete coagulation cascade. So that is we add the tissue factor and F6 that is the glycoprotein 2B3A platelet receptor blocker, and we use platelet mapping. And in platelet mapping, we use heparin, retilase, factor 13A, ADP, and arachidonic acid. So these are the following components which we add as reagent. Then the native TEG. Native TEG is the TEG in which we don't add any reagent. Only the whole blood is involved in the TEG sample. So ROTEM is also having similar modifications. So INTEM means this is actually the intrinsic factor. So intrinsic factor.
So what are these modifications basically for?
It's basically for the initial blood sample. Initial blood sample.
What is the purpose in ER? What is our concern in here?
Yeah, so there will be a modification in the values of the K-type alpha angle is all different in cases of each modification. So the initial which we have mentioned about the K time alpha angle, all is determined on the native TEG value, which is calculated on a whole blood. So that is
I didn't get it.
so
No,
initially
in
we
ER setup,
yeah
why do we need to use all these things?
yeah
Interm,
so
extem, heptem, aptem, and all.
yes in
That is a
trauma
rapid tech you have already
yes rapid
mentioned.
TEG yeah. All others are just additional which we use in the basic settings, not like completely based on ER. It is the different modifications which are present in TEG and ROTEM.
Just for completion's sake, you
Yes,
mentioned
yes,
all
yes,
these
yes.
things. Okay.
Yeah. So then X is the extrinsic factor. Extrinsic factor is used as activation, and that is the tissue factor. And heptem is heparinase. Aptem, that's a reagent called as aproteinin, and fiptem. And natem is what is the basic whole blood sample. So that is the native whole blood sample with no reagent. So this is the basic sample which we use in the case of ROTEM in common usual cases. So this again the same thing. Yeah. So the interpretation of the results. So as we have already discussed before, in case of a prolonged R time, so in prolonged R time, there will be prolonged clotting time. So that usually determines there will be presence of a factor deficiency, factor dysfunction, or even in presence of anticoagulants and severe hypofibrinogenemia and severe thrombocytopenia. So all these following conditions, the R time can get prolonged. And
So to prevent confusion, I think it's better you remember prolonged R time, factor deficiency.
and prolonged K time is again based on a prolonged clot formation time in case of as in ROTEM, and it also determines the factor deficiency, and alpha angle if it is reduced, it's again hypofibrinogenemia. So hypofibrinogenemia is the main component involved in cases of decreased alpha angle and prolonged K time. And if maximum amplitude is reduced, it mainly indicates thrombocytopenia or a platelet dysfunction. So these are the factors involved. And if there is an increase in the LY30 or LY60, the lysis time is getting prolonged. And in such conditions, it means there is a primary fibrinolysis or a secondary fibrinolysis, which requires the management with an antifibrinolytic agent. So this again the previous thing I mentioned before in
What
brief.
to transfusion?
Yes. So in the R time is the time to start the forming clot. It usually in an average time takes 5 to 10 minutes, and it is mainly determined by the coagulation factor, and treatment is FFP. K time is the time until which the clot reaches a fixed strength, minimal strength. It's of 1 to 3 minutes. It is mainly the problem with fibrinogen and treated with cryoprecipitate. Alpha angle is the speed of the fibrin formation, which is determined by an angle of 53 to 72 degrees, and the problem is with the fibrinogen, and again treatment is cryoprecipitate. And the maximum amplitude is the highest vertical amplitude of in the TEG, and that is 50 to 70 mm is what is the value, and that is problem with the platelets, and we can give platelets as transfusion, and lysis at 30 minutes. So it is between 0 to 8%, and if excess fibrinolysis is present, we can give tranexamic acid and EACA, epsilon amino caproic acid. So
This diagram is important.
this is one of the most important part in the TEG analysis. So in TEG analysis, we can see that in a normal TEG, we can see that the R time, K time, maximum amplitude and the angle is normal. So this is how the normal TEG looks like. And the morphology changes when there is presence of a usage of anticoagulants and in hemophilia. So in hemophilia, there will be presence of factor
Suppose
deficiency.
there is an increase in R time. See,
So if the
suppose
R time
you get a tag like that, the second diagram.
So R
then
is
you
prolonged.
should be suspecting. Yeah.
So R is prolonged, K is prolonged. So the clotting time is increased.
That is not K. That is not K.
Yeah, so me. Yeah.
K is just after
Yeah.
completion of.
Yeah.
Yeah, that is K.
Yeah. So between R and the K, so if it is getting increased, it usually indicates the factor deficiency, and so that is what is occurs. And we can see that the maximum amplitude also reduces in the, compared to the normal, and the ankle is also reduced. It becomes more acute in cases of hemophilia. If we use platelet blockers, like in thrombocytopenia condition, we can see that the R is normal.
So you understand what to transfuse here. If you get
The R is normal and the K gets prolonged. So here the K gets prolonged, and the maximum amplitude again reduces. So in this condition also, the maximum amplitude is reduced. So what we must transfuse is platelets. In case of fibrinolysis, we can see that fibrinolysis is usually occur in the cases of when we use a urokinase or streptokinase or a tissue plasminogen activator. So the presence of a tissue plasminogen activator usually leads to the R time is normal.
So if you check after post thrombolysis, if you check the blood and do a TEG, you will get such kind of a diagram.
So so here we can see that the LY30 is more than 7.5% and LY60 is more than 15%. So that is the increase of prolonged.
Ideally, it should be less than that.
Yes. So here is the condition where we give antifibrinolytics if in case if there is increased bleeding manifestations. And next is a hypercoagulation state. Hypercoagulation state, we can see that the R time and the K time gets very much reduced.
Yeah, that's
R
too
time
much
and
coagulable.
So it's
Two
too
extreme
much.
things. One is no coagulation at all, and the other one is hypercoagulable.
So there is increased number of clotting factors, and the angle gets more obtuse. So that's what occurs in case of hypercoagulation.
Short R time, obtuse alpha angle, short K time, and maximum amplitude.
So that is what occurs in hypercoagulation state.
And
so
lysis time is almost gone.
Yes.
There is no lysis there.
There is no lysis which occurs. So in hypercoagulation state is what I mentioned initially. In case of pregnancy we can see, and also in initial stage of DAC we can see a hypercoagulable state. But in DAC the main difference is initially there is a hypercoagulable state. Here we can see a hypercoagulable state, but then there is presence of a secondary fibrinolysis. So that is the difference in case of DAC compared to other hypercoagulable states. And stage 2 of DIC is a complete hypocoagulable state.
So mostly that is where you transfuse or give all DIC, you give what? Cryo and all.
Yes.
Stage 2.
So these are basically the different common ROTEM patterns which we can just tell. We can just exclude this initial part. All these initial parts are just excluded. So these parts are mainly excluded. If we just exclude these parts, this is what is actually the actual graph looks like. But we all add a small base to the glass. So that's how it goes. So initially if it's like a champagne flute, it means a fibrinogen deficiency.
I think it's better to study the other one.
Yes.
It's much more complicated.
So these are the usual diagrams which are usually commonly involved. So the test tube type. Yeah. So in case of a massive transfusion protocol, how TEG comes into picture. So that's what is mentioned. So if the patient comes in a field or in the ER, if patient is having a systolic blood pressure less than 70 or a systolic blood pressure between 70 to 90 and a heart rate more than 108. In such situations and along with a penetrating torso injury or unstable pelvic fracture, if EFAST showing presence of blood in one of the body regions, we can tell it that it is indicative of a class 3 or class 4 shock. Then we can activate MTP, and this according to guidelines we can go in a ratio of 1:1:1 or we can go into ratio of 2:1. So the RBC of 2 and FFP of 1. So 2:1 ratio is can be initially transfused as the initial resuscitation. Then we can order for the rapid TEG. The RTEG is the rapid TEG. And we can look for the activate the clotting time, and we can also look for the angle. So then our transfusion all depends on whether the following values. So when we have the activation clotting time, the clotting time is between 110 to 140 seconds. we just need to give only RBCs and FFP. But if the clotting time is again increased, we need to start like platelet and also cryoprecipitate. So that is how the management of blood products goes. And when we repeat the RTEC, if the
Basically,
patient,
activated clotting time you can't find out in TEG, right?
yes,
You'll only know R, K, alpha.
yes,
Actually, RTEC is
RTEC, in RTEC we can find the
In
activated.
R-TEG it is there. Yeah,
Yes.
that is the thing. And trauma, okay.
Yes, in trauma cases we can see the activated the clotting time. And if patient is again bleeding, we can continue the blood component transfusion based on the following TEG triggers. So we can see that here and if the activated clotting time is
So
more
in
than one.
trauma, basically you suggest only R-TEG, not
Yes.
the routine TEG.
So here we can see that if the activated clotting time is more than 110 seconds, we can give FP 2 units. And if alpha angle is more than 63, we can give cryoprecipitate of 10 units. And if the maximum amplitude is less than 55 mm, we can give platelets 1 unit. And if the lysis LY30, the amplitude, the percentage is more than or equal to 3%, we can initially start with tranexamic acid 1 gram IV, or this what
So
the
these things can
guidelines go.
may be applicable in CLD upper GI bleed also, right?
Yes.
Hemorrhagic shock. Maybe rapid TEG can be used.
So this is the another take-home message. Give tranexamic acid for LY30 more than or equal to 3% in case of a acid transfusion protocol in case of trauma. Okay. So this is just a comparison between the TEG and the ROTEM. And so the function is basically in TEG and ROTEM, it is basically functioning on the clot visco elasticity. So that is what is done by the TEG and ROTEM. Clot initiation is mentioned by R time in TEG, it is mentioned by CT, clotting time in case of ROTEM. Clot formation rate is mentioned by K time in TEG, and clot formation rate is clot formation time in case of ROTEM. The clot strength is mentioned as MA,
It's
maximum
basically
amplitude.
one and the same thing. Some different names are given for ROTEM and TEG, that's okay.
but the clot formation time is equal to R plus K, not just K.
R plus K, yes. Complete clot formation time is R plus K, yes.
Yes. And then fibrinolysis is by LY30 and LY60 in case of TEG, in LA30 in case of ROTEM. And sensitivity in case of TEG, it is less sensitive to in case if low fibrinogen is there and PT and PTT is low. But if it is more sensitive to low fibrinogen PT and PTT. So that's why ROTEM is more advantageous. We can be able to identify even in lower values of fibrinogen PT and APTT. So the turnaround time, usually the time of the whole procedure is slower in case of TEG and it's faster in cases of ROTEM. So in between surgery, if we need any component transfusion, it is better we go in ROTEM. TEG is basically a USA based study, it was the initiation, and ROTEM was initiated in Germany.
So basically the ROTEM is preferable.
Yes, ROTEM is having more advantage compared to TEG. And the number of channels, how many samples we can test at one time. So in TEG, it is usually 2 samples we can test at one time. In ROTEM, we can test up to 4 samples at one time. So that is the difference. And so in cases of trauma cases, always ROTEM is more preferred compared to TEG. And so that is the main differences between TEG and
Okay, anything more to discuss?